So these things are very, very important as far as a doctor who is handling the emergency department, right? The next thing is, right. So this is the principal management, the blueprint. We have something called blueprint. Blueprint means we have 5 steps here. You have to triage the patient, initial stabilization, direct history and examination, commence specific treatment, and ongoing care. So that is how we manage the patient. Even though we don't know much about pediatrics, you have to go through, or you have to know about these 5 steps. That is how we can manage the patient. The triage, initial stabilization, direct history and examination, commence specific treatment. The last one is ongoing care. So very important, all those things, right? So you can see the triage and positioning of the patient. Triage, we have a separate triage charts, especially we use in Karapedia. I don't know the other places, but this chart is from England, and a triage, appropriate place and appropriate time. So triage is very important, which is done by a nurse, and very important to triage the patient. That is how we calculate the severity of the importance of the disease. Then the positioning. Positioning is very important. Usually we keep the upright position, seated position in airway and breathing issues. The best place is parents' lap. So ask parents to keep the baby in their lap and give oxygen and manage them. Sometimes if it is upper airway obstruction like tonsillitis, tonsillitis or esophagitis, so it's very difficult. I mean, it's terrible when you disturb the patient. That can aggravate the situation, and that may be the cause for the death because of the upper airway obstruction. So you have to be very careful in that situation. You have to manage gently and softly. Sometimes you don't have that colleague like myself, but you have to understand it's very gentle and soft quality. You have to improve or practice, right? So don't ever forget airway, breathing, circulation, and disability exposure. I always tell this is a Mecca for emergency doctors. Without airway, breathing, circulation, disability, and exposure, you can't manage any patient. So we have to try the patient and position the patient. Then patient comes to the emergency department. So according to the triage, there will be category like Cat 1, Cat 2, Cat 3, Cat 4. So Cat 1, directly to the resuscitation area, you don't have waiting time, 0 waiting time. Cat 2 patient goes to sometime acute or treatment area. You have a 10 minutes to sort of attend the patient. So likewise, then you have to attend airway, breathing, circulation, disability, and exposure. Right. As I earlier told you, like you have to keep in mind this is a child and they have a different physiological aspects, and this different physiological parameters, and likewise you have to manage this patient, right? So airway wise, we have to manage 2 or 3 P's. What do you mean by P's? The patency and protect. The third one is in trauma patient, protect the cervical spine. Patency is very important. You have to suck out the secretion and protect the airway. So if there is a tongue, you can put a oral airway to protect the airway. Cervical spine, you can put a cervical collar, right? So very important. So obstruction, yes, very important. Obstruction, as I said, there may be a tonsillitis, large tonsils, or sometimes there may be a foreign body. There may be a epiglottitis. There may be a laryngoparengitis, something like that. So then you have to keep in mind. Then don't straight away go and suck out the secretion. So suck out the secretion is very important. There is any secretion, but imagine rolling of saliva in case of tonsillitis, or in case of epiglottitis, you worse the situation. So you can apply oxygen, and you can use airway adjuncts like acid, oral airway or nasal airway. Sometimes airway adjunct may be intubation, right? So it's very important go step by step. Patency, protect the airway, then obstruction, then suck out the secretion, oxygen, airway adjunct. Then meanwhile, you can put a pulse oximeter and check the saturation. So workup breathing is very important. Effort of breathing, efficacy of breathing, effect of respiratory. So this is very important as far as any doctor is concerned. Effort, efficacy, and efficiency of respiratory. Right. Effort of breathing. What do you mean by effort of breathing? You can see these pictures. Respiratory rate, very important. According to physiological parameters, you can see you can check the respiratory rate. Then the accessory muscle use, very important. That means patient is in severe respiratory distress. Flaring of the nostrils. You can see the flaring of your patient's nostril. Then child position and sounds. Sounds means, what are the sounds we are talking about? Sound means stridor, grunting, and wheezing. Stridor means primarily inspiratory noise. The upper airway pathology can get in, as I earlier said, foreign body, then the tracheobronchitis group, and then the tonsillitis or in epiglottitis. So you can get stridor. Grunting, that is the expiratory with partially closed glottis, alveolar pathology, right? So you can get it in who. And wheezing, the primarily expirated noise. Most of them have good experience in wheezing. So wheezing is always an expiratory noise due to bronchoconstriction. The next step is acute severe asthma management. I'm not talking about details in acute severe asthma management. You have to know a few things. It's a severe and critical. It doesn't mean patient. I mean, if patient have a high pitched wheezing, doesn't mean that patient's severity is high. Sometimes silent chest is pre-terminal. You have to understand this is the thing. So severe and critical patient you have to identify. Examination tips. Wheezing is not a good mark of severity. As I earlier said, the best measure of severity are general appearance. That's why you need good practice in pediatrics. Mental state, that patient is irritable, drowsy, that means brain hypoxia is there. So that is because of the VQ mismatch in the lungs due to reduced oxygen intake. Workup breathing using accessory muscles and recession. So this is the thing. The asthma is bronchial asthma is you have to use bronchodilators temporarily wise and then use anti-inflammatory as a permanent solution. So nebulization is salbutamol and ipratropium. So you can use over 1 hour, 3 cycles. Then steroid-wise IV hydrocortisone or oral prednisolone. Then if not responding, then you can go for max sulfate. And if the severe cases, you can go for IV salbutamol, IV ketamine, sometimes IM adrenaline or nebulization in stridor allergic situation. Intubation and ventilation is the last option. So don't give up and start from the beginning and start from airway breathing wise, like nebulization, steroids, and max sulfate. I mean, no hurry to give steroid, but the most important thing is nebulization, right? Steroid will take about 4 hours to get this action. So then you have time. So nebulization is very important to give it and relieve the bronchoconstriction. So that is how to manage the asthma. So early recognition of shock. It's very important. This cardiovascular wise. Cardiovascular signs, effects of circulatory inadequacy. So this is very important to identify the shock. So if you keep patient shocked for more than half an hour, that can precipitate multi-organ failure. Try to relieve the patient as soon as possible. So start IV fluids, then inotropes, vasopressors early as possible. Right. What are the signs? You can get it in shock. Increased heart rate. Sometimes it may be bradycardia, that is pre-terminal. Pulse volume. Yes, low pulse volume. In pediatric situation, capillary refilling time is very low. And capillary refilling time is very high. Sorry, it's more than 2 seconds. And blood pressure, you can see It's very difficult to check the blood pressure, but blood pressure is low. Cyanosis despite of oxygenation. Why? There is no blood to transport the oxygen because of shock. Marked tachycardia, gallop rhythm in heart failure situation, enlarged liver in right heart failure, absent femoral pulses. So those are the very important cardiovascular signs in a child who has got shock. So we know that there are 4 types of shock: obstructive shock, distributed shock, cardiogenic shock, and hypovolemic shock. What are the examples for obstructive shock? That is pneumothorax, hemothorax, sometimes cardiac tamponade. Distributed shock is the examples are septic shock, anaphylactic shock, sometimes spinal shock as well. Cardiogenic shock, it's very rare in pediatric situation, but ischemic heart disease, arrhythmias are not rare. And then you can get cardiomyopathies. Then hypovolemic shock, yes, you can following a trauma, bleeding, then diarrhea, vomiting situation, burn situation, you can get hypovolemic shock. So that is how you have to manage. Each situation has its salient features to manage. So it's very important to identify the type of shock, manage accordingly. Right. So how do we manage? Fluid bolus 20 ml per kg at resuscitation unless patient have heart failure. Further boluses, no improvement to first bolus, then you can give another bolus. Consider then inotropes, especially noradrenaline, like vasopressin situation, intubation, central venous pressure monitoring with third bolus. Consider IV antibiotics like cefotaxime, ceftriaxone in case of suspected case of septic shock. Think about other causes. So it's very important to do it as soon as possible. You don't have much time to manage the patient. Right. The next step is disability. It's very important. Disability wise, you check the GCS or AVPU and pupil size and posture and blood sugar level. It's very important to know that there are 2 types of Glasgow Coma scale for pediatrics. Less than 5 years. Sorry, yes, less than 5 years and more than 5 years. So less than 5 years, 2 to 5 years, and less than 2 years. Likewise, they have different GCS charts. So you have to work according to the patient's age. So otherwise, you will get false details about GCS. So pupils are very important, whether it's equal or unequal. Pinpoint pupils, like in pinpoint pupils, what are the things? Poisoning situation, then intracranial hemorrhage, especially pontine hemorrhage. Though those are the things you have to know. Posture is also very important. Decerebrated and decorticate position. So those postures suggest the prognosis of the disease. Then the blood sugar level. It's very important. Blood sugar level. It's a reversible process. If you don't do that, that's a criminal thing. So 2 ml per kg, 10% glucose. All right. So seizure management is very important. Increase the cerebral metabolic rate that will produce a sort of a brain edema. The increased cerebral metabolic rate will increase your lactate level as well. So increased sympathetic activity, release of catecholamine, peripheral vasoconstriction, and increased blood pressure. So increased cerebral blood flow to provide the necessary oxygen and energy. So that is how your lactate level will increase. If conversion continues, lactic acid rapidly accumulate, then there will be rhabdomyolysis and other features. Subsequently, cell death and edema. So you have to control this seizure as soon as possible. So first, we have 5 minutes, 3 steps in managing this conversion. First 5 minutes, you have to protect the airway and start oxygenation. And try to put a cannula, and you can start lorazepam IV in IV. If you don't have lorazepam, in Sri Lankan situation, we don't have much lorazepam, especially in peripheral units. So then you can use midazolam, IV, IEM, or bucket. Then diazepam, you can use IV and rectal. So doses are there. So basically 0.5 milligrams bucket, midazolam 0.15 milligrams IV, and 0.2 milligrams IM. Then after about 10 minutes, you can start the second dose of lorazepam. There is no response. What you can do is you can go for the second line treatment. So either levetiracetam. Nowadays we use levetiracetam, but phenytoin and phenobarbital are also used. Nowadays we can use levetiracetam as well. Then if not responding to levetiracetam, then you can start phenytoin. But no response, then you have to intubate the patient and start anticonvulsants. Keep in mind that this is a very serious situation. So patient may end up with some pain hypoxia. This is a permanent damage. This is a developing brain, and I mean you have to address that as soon as possible, right? But exposure-wise, as you should know that we are very dark color skin person, but you have to take the temperature. The rashes, it's very difficult to catch up, but still you have to see whether there is any rashes, especially in case like meningitis, meningoencephalitis. Evidence of trauma. Trauma may be two-story trauma, like it may be child abuse, like non uh, uh, child abuse trauma, and it may be a real trauma situation, abnormality, deformities, and things. Then you can check the nappies, whether wet, dry, or whether there is any stool with bloody stool are there. So that is how you check the nappies as well. This is called exposure. Right. Please remember these 4 steps. These are pre-terminal. If you don't attend immediately, then patient will die. Any patient with cyanosis, unless patient is having chronic cyanosis, so patient will die. That means terrible situation either due to hypoxia or hypotension. Then silent chest. Yes, then you have to do something immediately, otherwise patient will die. The oxygen saturation is less than 85 in air. Then again the thing. Then the hypotension. It's a very important situation. Right? So those are the very important things you have to remember, and you have to treat for these patients. Don't ever forget these pre-terminal things, pre-terminal signs and symptoms. If you miss those things, that will be the end of life. Right? So we have to be very, very careful about that. Right. Don't ever forget pain. Children, they feel pain. Inadequate analgesia is very common in pediatric situation because you think that patient can go into respiratory arrest, respiratory depression, and likewise, but you have to give the pain. That is a very important thing. Strategy is to help, and you can get good cooperation with the child as well to give good pain relief. So don't ever forget pain management. They have different pain score here, so you can see the face, uh, I mean chart. So like sorry, they have ladder chart. So there are different charts, but I used to use with this one. This is a face chart, so very important with pain management. Right. The next step is very important. Measure, monitor, and reassess the patient. Fever, yes, core temperature. Sometimes it's not ideal, but you have to do it. Tympanic and axial temperature can be unreliable. Right. Core temperature is very important. Tympanic and axial temperature can be unreliable. Even core temperature may be misleading you. Blood sugar level is very important, as I earlier said. You have to treat that. First, you can give orally. Patient is okay, but otherwise you can give IV. Right. Monitoring is very, very important. If you have any doubt, what you have to do is reassess the patient. How do you reassess the patient? Yeah, breathing, circulation, disability, and exposure. So those are very, very important things. Don't ever forget. Then you can take a direct history and examination. Imagine CAT1 patient comes to your resuscitation area. I mean, you don't have much time to take history and examination, but later you can directly ask the questions and examine the patient properly. So environment is very important. It should be a friendly environment for the patients baby as well as the parents. Communicate with the child and not just the parent. So communicate with the child, but otherwise you can't make that one with the child. Be honest, very honest. All right. So respect the child, modesty, flexible approach. Right. So most innovative, I mean, least innovative and most innovative. So very flexible approach should be there. Right. It not be sort of an artificial situation. So you have to be very gentle, as I earlier say. Good friendly environment should be there, and you have to speak very soft. I don't have that ability, but still you have to do it properly. Right. Such comments specific management, as I earlier said, like asthma, cardiac failure, respiratory failure wise, you have to start specific management. But you can see that the last thing is cardiac arrest. You can see airway obstruction or in-body asthma, poor bronchitis. The respiratory depression, convulsions, sepsis, poisoning, increase ICP, alveolar chest wall failure. So pneumonia, chest trauma. So that can go into respiratory failure, then cardiac arrest. Then fluid loss, fluid maldistribution like sepsis and anaphylaxis. I say that distributory shock and heart failure, cardiogenic shock, fluid loss, that is hypovolemic shock, circulatory failure, and ultimately cardiac arrest. So the first step, you have to assess the patient's parameters, then the cause and the result is good. So it's very important to assess the patient. You don't need to know A to Z in pediatrics. Even I don't know anything much about deep things about my pediatrics. But airway, breathing, circulation, disability wise, you have to manage. Ongoing care is very important. Reassess, and then assess. Reassessment is very, very important. Right? Don't do it haphazardly. Start with the airway, breathing, circulation, disability wise. Disposition wise, you have to transfer patient to ICU, the ward, or sometimes it's maybe operation theater. Now you have to retrieve the patient. These are very important things. Handover. I think you have to use to this situation, ice bar situation, very important to hand over the patient. Give all details about the patients and hand over the patients. Right? So you have, this is an art. Communication is an art. So you have to use that. You have to practice that and get that ability. Right, that's all. Any questions you have to ask? I'll give you 2 minutes. No questions. Yes or no? That means you have understood everything, right? Good, very good. I think this time we have got good brainy pre-interns, right? It's not that like the last time, brainy pre-interns. So we'll see how do you do. Right. In summary, this is very important. Children are not small adults or half adults. You have to keep in mind that red flags, very important in preparation for a patient with pediatric patients. So blueprint is the management plan we have, and don't ever forget these pre-terminal situations like cyanosis, silences, saturation less than 85, and hypotension. So very important those things. Thank you very much. All the best for your future. Thank you. I think next lecture is going to do Dr. Chamar Bergudaraj. Chamar, are you with us?
ඊට පස්සේ
Dr. Bandara Ekanayake will do the next lecture. Instead of Dr. Evaluation of short
ඒකේ තියෙනවා හොඳයි කියන්න වෙන විදිහක් නරකයි නම් එහෙම හැදේ කරපොයි
So just until the lecturer joins, I will show you the tomorrow's lecture. Dr. Bandar, are you there? Hello.
Give me 1 minute to upload my site. Okay.
Sure thing. Okay. So next lecture is by Dr. Bandara Ekanayake, Consultant Emergency Physician at NHSL on shortness of breath. You can start, Dr. Bandara.
Thank you very much. Hope everybody can see my slide.
Yes, yes.
Okay, thanks. Okay. I'm going to talk about basically the acute shortness of breath and its management in emergency department. Okay, and firstly, I will discuss a case, and then we'll go through structured approach, how to identify and how to manage, and basically we investigate and giving the proper management, and some other tips of as a overall. Okay, these are my structures, the content of the lecture today. You have a 69-year-old male who is coming with worsening of difficulty in breathing for last few hours. His main presentation, apart from he is taking tablet for hypertension. That is the only history, the short history or the focus history we can get from the patient. My first question is, how do you approach this patient? Okay. Okay. In the initial assessment, basically what you want to do is you want to triage the patient, but it is usually done by the triaging officer or the triaging nurses. This patient usually categorized into the category 1 or 2 depending on their severity. Okay. Their severity basically depend on patient clinical presentation, vital parameters, and added with some adjuncts like saturation and things. Okay. Apart from that, patient need to be positioned. For example, if patient is really breathless, they like to stay in upright position. But if patient is having any trauma, or if there is any suspicious of cervical, especially spinal cord injury, especially the cervical cord, then patient need to be line and manually line stabilization. Okay. Therefore, patient need to be positioned depending on the patient's condition. But if it is a non-trauma case, then basically patient need to be positioned as patient optimal. It's like a patient convenient, not our convenience. Okay. Therefore, we need to go through ABCD approach. Okay, even though it is simple ABCD, you need to identify the life-threatening problem and you need to treat and then and there. That is called resuscitation. In emergency department, each and every patient who admitted to the A&E need to have a primary survey or ABCDE assessment amalgamated simultaneously with resuscitation. Okay, that is our main priority. Why we want to do the primary research, primary survey or initial ABCD assessment is basically to identify any life-threatening or any limb-threatening or any organ-threatening injuries. We want to identify that then and there and need to start resuscitation immediately. Okay, that is the main aim of doing primary survey. For this patient, we have approached in a structured manner. We want to look whether the patient is having a patent airway. In the patency of airway, what we want to look for, whether the patient is having a fully patent airway or partially collapsed airway or completely obstructed airway. To analyze this one, we need to talk to patient. If patient can complete sentence without any distress, then probably not 100%, probably patient is having a patent airway. But if patient is having any impairment, like any features or any signs that denote patient is having a partial airway obstruction or complete airway obstruction, we need to act immediately. Okay, and the signs that usually there are like patient might have a secretion, patient might have a airway noises. For example, patient might have a stridor, patient might have a snoring sound, patient might have a wheezing or grunting. Depending on the level of obstruction in the airway, this airway noises might change. For example, if patient is having a stridor, that means he is having a significant or threatened partial obstruction of airway, basically the major airway. Okay, if patient is having a grunt, if patient is having a snoring, that means probably patient is having an upper airway obstruction, probably because of tongue falling back. If patient is having a wheezing, that denotes patient is having a smaller bronchial obstruction that causing wheezing. Or if patient is having a grunting, that denotes patient is having a small airway plus or minus alveolar collapse. These all signs you can think that this patient, okay, this patient is having a bit of this patient is having a partial airway obstruction, and probably this is the level. Okay, this is how you need to address the airway. In breathing assessment, I will the patient's actual detail after I'm going to assess this patient. Okay, I will initially summarize what are the points I am going to look for in ABCD, and then I will give actual figure that patient had. Okay, in breathing, what you're looking for, whether the patient is having any respiratory distress. Okay, we have completed A, but A looking for whether the patient is having a fully patent airway, partial obstructed airway, or complete obstructed airway. Okay, we have assessed that one. Oh, okay, I forgot to tell that if patient is having a complete airway obstruction, either patient is having a respiratory arrest or patient is having apnea. Okay. Okay. In breathing, what you're looking for basically to identify whether the patient is having any respiratory distress. To identify respiratory distress, you need to look for signs. What are those? Respiratory rate. If patient is having a high respiratory rate, yes, patient might have a respiratory distress. If patient is having a low respiratory rate, that is called bradypnea. Like our normal respiratory rate is usually 12 to 20. If more than 20, it is also worse. If patient is having a bradypnea, that is less than usual, it is denied less than 10. If patient is having a bradypnea, yes, it is really worse. Even it is significantly worse than patient is having a tachypnea. That means it's a pre-imminent respiratory failure. Okay. Next thing is you need to identify whether the patient is using any accessory muscles. What it denotes? It denotes patient is using accessory respiratory muscles to support his respiration. Okay, that means he's going to have an exhaustion. Okay, then next thing what we want to expect is to exhaust the respiratory muscle. Then you need to percuss and need to auscultate whether there is any adult sound or any significant finding you can write. Okay, then you need to look for patient saturation. Patient saturation, you need to get the proper waveform. Otherwise, that reading is completely wrong. The patient is having a proper waveform capnography, proper waveform saturation capnography, proper waveform saturation reading, then it is usually correct. Okay, you need to take that correct reading. In addition, in emergency department, we are doing focus scanning. In focus scanning, basically to identify patient is having any life-threatening lung problem, like tension pneumothorax or a pneumothorax, hemothorax, and these kind of a thing. Okay. I summarize. We have done airway assessment and then breathing assessment. Breathing assessment mainly look for if the patient is having a respiratory distress. You can amalgamate, you can adjunct by getting saturation probe and the focus scan, that is point of care ultrasound scan. Then we go into the circulation. Okay, circulation, what you're looking for, whether the patient is having any pulse rate problem, any problem in pulse rate or any blood pressure. Pulse also, rate and rhythm is very important because sometimes patient might have a rhythm problem which is denoted by the shortness of breath, and patient might have a low blood pressure. We need to identify that the patient is having any significant. Okay. In addition, you need to look for capillary refilling. Okay, which is a good marker of patient is having a peripheral shutdown, peripheral collapse. In addition to identifying the signs, you need to get 2 large bore intravenous access, ideally antecubital fossa, ideally, because it is a large way. And you need to get the basic investigation. Basic mean what basic in emergency department is usually venous blood gas or maybe arterial blood gas. Okay, why we want to have a blood gas? We want to identify any electrolyte abnormalities, any acid-base status, any patient respiratory distress, which all we can identify with the blood gas. Usually we prefer to have a venous blood gas rather than arterial blood gas because almost all the cases we can get exact correct reading with the arterial blood gas, except patient is having a saturation less than 92. I will rather recommend you to go ahead with the arterial blood gas rather than doing the venous blood gas. But all other cases, please do venous blood gas. No point of doing the arterial blood gas. Okay. In circulation, what you want to do, other thing is you need to take 12 lead electrocardiogram, ECG, and if patient is missed in the point of care ultrasound scan to identify any pericardial location, you need to do it here. Okay. Therefore, in circulation, what you want to look for, pulse, blood pressure, capillary refill. In addition, you need to get intravenous access, basic blood investigation, and 12-lead ECG. And E, patient might be agitated because of hypoxia. You need to identify whether is there any other thing that can cause shortness of breath or dyspnea in this patient on the neurology point of view. I will explain the causes later. In E, you need to look for whether the patient is having any cardiac problem like heart failure, congestive heart failure, patient is having a peripheral edema or right heart failure, and the patient is on catheter, dialysis catheter, and especially you need to identify whether the patient is having a kidney failure, because sometimes only presenting feature patient who is having a significant anemia is the shortness of breath, because he is having a very low oxygen because of very low hemoglobin and other features of chronic lung disease. Okay. This is our patient. He is a 69-year-old, as I mentioned before, coming with a few hours of difficulty in breathing. And his vital, he's talking at the moment. That means at the moment his airway is okay. And his respiratory rate is 28, saturation 92 on room air. And pulse rate 104, blood pressure 147 by 78. He is anxious, but GCS is 50. Temperature is normal. Okay. Here, basically, I am really worried about the patient, whether the patient is having a respiratory distress. Okay, because patient is having a high respiratory rate and low saturation. In addition, he is having tachycardia, which is also feature of hypoxia, and is anxious. Is also denote patient where the patient is having a hypoxia. Okay, and this patient basically coming with developing short difficulty in breathing over few hours, and he is having a respiratory distress. My first question: what is the focus of your initial management? Focus means whether you're going to do anything in the initial management. Yes, my main worry is whether the patient has an impairment of oxygenation or whether the patient is having a problem in A. For what? For this, what are you going to do? I want to give patients oxygen. There are so many myths we have had during past, because sometimes we don't know what mask or what the probe or the oxygen probe you're going to apply. Okay, this is a descriptive assessment of patient's oxygenation or delivery device, oxygen delivery device. If you have a patient who is having a saturation of 92, are you going to give oxygen with nasal or normal face mask, that is Hudson mask, or are you going to give with an unrebreathing face mask? It is quite challenging. But if patient is having a significant hypoxia, that is patient is having a saturation of 92, then definitely I will at least give Hudson mask or normal face mask, or I prefer to have a non-rebreathing face mask than the nasal cannula or anything. Okay. For patient who is coming with respiratory distress, you need to start oxygen, and you need to have a target. You don't give oxygen. Please never give oxygen as like a universal treatment, because sometimes if patient is coming, they like saline, oxygen. Please don't do this one in your life, because oxygen is a medicine. You can't use over, so you can't use under. Therefore, you need to give oxygen in an appropriate manner. It is a prescription-based medicine. Okay, even though it is not properly practicing, please practice in a professional manner, because oxygen is a very costly medicine. Okay, oxygen. For oxygen, if patient need oxygen, okay, suppose you're going to apply oxygen via the face mask. How many liters per minute you want to give? At least 4. Like some people I have even observed that some people is wearing oxygen normal face mask, having a 2 liter of oxygen running. It is very utterly useless, because patient is rebreathing his carbon dioxide. Therefore, please, if you are starting a treatment, do it in a proper manner. Okay. For a patient who is having a in face mask, normal face mask or the Hudson face mask, you need to at least have a 4 liters per minute, and you can go up to 10 liters per minute. If patient is not acquiring your target saturation or target level of oxygenation, you need to go more advanced one. That is good. It is if you are going to put patient on non-rebreathing face mask, you need to start at least 10 liters per minute, and you can go up to 15 liters. Okay. Other one, what you can do is you can put an RBM and give significant, I mean, like 10 to 15 liter of oxygen as an initial, and then you can step down. That is a good way of doing this. So you can increase by putting first face mask and then non-rebreathing. Okay, whichever appropriate for the patient's respiratory distress. Okay, it should be individualized, not for each and every patient have a same devices or same level of oxygen, same level of same rate of oxygenation. Please do it on the individual basis, not for every patient. Like as I mentioned, not saline oxygen. Okay. Okay. Why it is important you to have a oxygenation very correctly identification of saturation, because you know that everybody have gone through their physiology in second year of their medical school. You know that you have a shoulder point in the oxygen dissociation curve. Usually it is varies from 90 to 92% of saturation, and from this onward it's drastically drop even though you have a significant level of oxygen, partial pressure of oxygen in your arteries or blood. Okay, therefore it is important to identify. But this target level of saturation depending on the patient condition, patient background history, patient chronic problem, you might give oxygen 88 to 92. Some patient you go beyond 94 level. Okay. These are the oxygen delivery devices, and with the flow rate, you can see that you're going to give partial fractionated oxygen FiO2. Like for example, if you are going to give nasal cannula 1 liter, that is you're going to give FiO2 of 24%. So if you are giving patient who is non-rebreathing face mask of 15 liters, you can achieve 60% of target. Okay, even it is same as the 60%, and it varies from 60 to 85% non-rebreathing face mask. Okay. Okay, now what we have done is already we have gone through. You have had a 65-year-old male who come in at the worsening of shortness of breath for last couple of hours, and you have assessed and you identify that patient is having a respiratory distress, significant respiratory distress. Now you started oxygen, and then first one you identify that patient is having an airway plus or minus breathing problem, and then you have a started oxygenation as a treatment. Then you need to think why this patient developed respiratory distress. Okay, why this patient developed respiratory distress. Under the sun, any cause, anything, any etiological factor can present as shortness of breath. Okay, there are so many causes. You can see, I can give 10 slides of how the patient presenting with the shortness of breath to the emergency department. But what our aim is to identify life-threatening injuries, not the patient who is having a fibrosis, or patient is having a like any chest wall abnormalities, or patient is having a minor aberration coming with the shortness of breath because of anxiety and this. But you need to identify any life-threatening injury which comes as a shortness of. What are the life-threatening injuries which comes as a shortness of breath into the emergency department? If you are comparing the patient who is a patient's pulmonary system, it can be anaphylaxis, angioedema, or airway obstruction, pulmonary edema, pulmonary embolism, and patient may have a trauma related like tension pneumothorax, cardiac tamponade, open pneumothorax, and okay. In cardiovascular system, basically the pulmonary edema, or patient might have acute coronary syndrome or arrhythmia, or they might have pericardial tamponade. But others are not that significant life threat. Infectious causes wise, patient might have a any infection which is related to shortness of breath, like epiglottitis, significant pneumonia. Okay. Trauma-related things I have mentioned. In abdominal causes of shortness of breath may be ascites or obesity, and metabolic causes, especially recently, like 2-3 days before, I had a patient who is coming with a significant shortness of breath. There's no features of pneumothorax, no features of pulmonary embolism, anaphylaxis, no features of pneumothorax or anything. But patient is severely acidotic because of acute renal failure. Therefore, under the sun, any cause can come with the shortness of breath, but you need to identify what is the life-threatening cause. Okay, you need to identify the cause. Otherwise, no point of giving oxygen liters or 1,000 liters. You giving just given like a paracetamol to fever. Otherwise, you're not going to identify the cause. You're not going to identify the cause. If you're not going to identify, patient will die on in front of you. Please identify the cause why this patient. At least working diagnosis. 3-4 working diagnosis is completely rational. If you can't identify exact pathology, you can think that this is my working diagnosis, maybe pneumonia, maybe sepsis, maybe
I think Dr. Bandara has got some connection issues. He will join shortly.
Can you hear me?
Yes, we can.
Yeah. Okay. Sorry for the technical error. And upload the life-threatening causes, and then they are depending on their acuity. And you need to, what you want to emergency department is to identify mainly life-threatening problem, and you need to treat them. Okay, fine. You can amalgamate it, you can simultaneously do monitoring. For example, airway and breathing, you can get the saturation, and breathe the circulation, you can do the blood gas, and you can do the pulse scan, and you need to get the blood glucose level. And in addition to that, you need to do this ECG, and D, you need to do the assessment of the mental status as well as the blood sugar if it is not done in C, and you need to identify temperature. Okay, and these are the investigation what you want to do. Okay, this patient, and later who is, you can remember that this is a 65-year-old man who come in with the shortness of breath, and then initially he had some respiratory distress, but now he developed significant worsening of his swelling, especially lips and the tongue, and patient develops stridor. Okay. For this patient, what are your differential diagnosis? As I mentioned before, what you want to do is you need to identify the cause. Okay, you need to treat the symptomatic first, and then you need to start the resuscitation, but you need to identify the cause. Otherwise, if you're not correcting the cause, patient is going to die in front of you. Okay, for this man, acute severe shortness of breath for basically for a couple of hours. Who is a 65-year-old man. He does not have any other significant etiology, but he's coming with this one. My main differential diagnosis are whether the patient is having anaphylaxis, plus or minus angioedema, or foreign body upper airway obstruction, or any infection, or especially the neck space infection. Okay. And what is my treatment? I need to identify whether the patient is having the airway, the level of obstruction, and you need to treat. Sometimes you might need to go ahead with the front of neck axis that is called fauna, or you might need that immediate intubation. Okay, but it is basically dependent on your case. In addition, you can give adrenaline and you can give steroid, because this patient, most likely patient is having angioedema, but you need to exclude anaphylaxis as well. For patient who is coming in this one, you need to give IV adrenaline, that is, that 0.500,000 in the anterolateral aspect of time. Okay, and in addition, if patient is having the features of angioedema, you need to go to FFP, and you need to do the disposition correctly. I have summarized that the management step or management strategies, patient basically coming in the shortness of breath to the emergency department. These one thing is patient come with the acute pulmonary edema. Acute pulmonary edema, you need to give adequate amount of oxygen, not over, because over oxygenation can vasoconstrict, and oxygenation can vasodilate. Therefore, you need to give adequate oxygenation, and you have to have a target. You can initiate non-invasive ventilation as a therapeutic measure. It has a very high significant improvement in mortality, very significant improvement in mortality. Therefore, early NIV is very significant in patients' mortality and hospitalization. And in addition, you need to give nitrate unless it is really contraindicated. For example, if patient is having a significant, very serious aortic valve, then it is relatively contraindicated. But otherwise, usually patients are tolerated by nitroglycerin. And diuretics. What we usually starting is furosemide, but please never start furosemide as a first line treatment for a patient who is having a pulmonary edema. you might start you might do diuretics like a furosemide in later on to clean expel your water in the body, because if you're given the furosemide or if you're given the diuretic in early, it takes at least 1 hour for furosemide to act. For a patient who is having a decompromised renal system, renal circulation, how it can come as an acute benefit. Therefore, please don't give furosemide unless really indicated. If you want to give furosemide, you can give, if patient is on furosemide, you can give 1 to 1.5 times of patient's usual furosemide dose as the intravenous dose. But if this patient is not taking any furosemide or any diuretic before, please give small dose of furosemide or small dose of diuretic like 20 milligram intravenous furosemide. Okay, and as we mentioned, no tons of furosemide, no morphine, because morphine is having a vasodilatation and it is irrational vasodilator. Therefore, not to give furosemide, not to give morphine in real acute pulmonary edema. But later on, once your patient is recovering, then you can give shot of furosemide, dose of furosemide to expel extra water from the renal system. Okay. Therefore, patient who is coming with the pulmonary edema, particularly oxygen, early non-invasive ventilation, nitrate. Later, you can think about furosemide, not furosemide first. Okay. Then patient who is coming with acute coronary syndrome, usual the old school theory is the stat doses. There's nothing called stat doses in this whole world. This is a very non-functional stat doses. You can give antiplatelet. Okay, these are aspirin or 2,3 PG inhibitors that is called clopidogrel or prasugrel or whichever you have. You don't want to give statin because statin doesn't work in acute setting. Okay, therefore, if patient is coming with acute coronary syndrome, you need to give aspirin, clopidogrel, anticoagulant, and you can go ahead with the pre-perfusion, either medical or mechanical pre-perfusion. Okay. I think my next lecturer is going to discuss about acute coronary syndrome, the case, and then I'm not going to go into the detail. And the next thing is patient who might presenting with shortness of breath might have anaphylaxis. What is the main treatment of anaphylaxis is adrenaline, all the time adrenaline. So you need to stop causative agent if you know, like if patient is on antibiotic or anything, you need to immediately stop that one. And then you need to give fluid initially you need to give adrenaline 0.5 milligram or milliliter 1 in 1,000 in anterolateral aspect of time. In addition, you need to give intravenous fluid all the time, adrenaline, because each and every 5 minutes you can give adrenaline if patient is not responding. And apart from adrenaline and intravenous fluid, usually the crystalloid, apart from that, there's no other added advantage of giving anything. Initially, what is the guideline is recommending is antihistamine and steroid. But steroid, yes, steroid is useful because it prevents secondary reaction, the wave of anaphylaxis. It prevents not 100%, but it has a significant level of prevention. But antihistamine, there's no benefit of giving antihistamine for a patient who is anaphylaxis. Allergy, yes, but not for the anaphylaxis because antihistamine, one thing is it can cause sedation and the patient might confuse. We don't know whether the patient is confused because of hypertension, hypoxia, or because of the antihistamine. Therefore, please don't give any other unnecessary treatment in the emergency setting. And one thing is, as I mentioned, one thing is patient might be sedated. Another thing is this even antihistamine is no point to act because it has, even though it has an antihistamine effect, it is not going to do anything because already released histamine is already done the damage. Therefore, we need to prevent mast cell degranulation, because that is the main pathophysiological the target is the mast cell degranulation. Adrenaline treating everything, because adrenaline prevent mast cell degranulation, it stimulate heart, it vasoconstrict and everything, doing betterment for the anaphylaxis. Therefore, all the time if patient is coming with anaphylaxis, treatment is adrenaline and intravenous fluid. Okay, and then you can give leisurely hydrocortisone, and no point of giving antihistamine. Is given to making the patient weak. And you might have a patient who is acute severe asthma, acute severe COPD, or life-threatening asthma. The patient who is having a asthma or COPD, sometimes you might have a combination, that is overlap syndrome also. Therefore, you need to start with an adequate level of oxygenation depending on the patient's background. And you can start with non-invasive for a patient who is having a COPD, but there's a bit controversial point for the starting non-invasive patient having asthma, but definitely it is mortality benefit, having a mortality benefit of the patient is having a COPD exacerbation. Okay, and you can start nebulization with salbutamol and ipraven, depending on the patient level of distress, and you can continue with. Okay. And the steroid. Don't ever forget a steroid for a patient who is having a COPD and asthma. Patient who is having an adult patient who is coming with the severe asthma, you can go ahead with the 40 milligram and COPD 30 milligram of medicine. Antibiotic is usually indicated if patient is having infective exacerbation, otherwise it is not usual. And you can combine with magnesium sulfate, and you need to get the expert opinion, especially the intensivist, for you to manage the patient rest. Okay, because sometimes patient might need intubation, patient might need the critical care assessment and frequent assessment. Therefore, especially patient need at least HDU care, or ideally in intensive care support. Okay, and basically what you want to do is need to identify the cause. That is why I'm going to give this or the strategies of management of these specialized cases. And the cardiac tamponade, you need to do the pericardiocentesis and the pulmonary embolism. What you can do is you need to anticoagulate the patient, and the pneumothorax, ancient pneumothorax, you need to needle decompress, and the thoracostomy. Needle decompression, usually the new ATLS guideline is usually for a patient who is have a tension pneumothorax. You need to needle decompress in the safe triangle of the second intercostal space with clavicular line. Usually it is in the safe triangle. And the upper airway obstruction, depending on the cause, you can give nebulization of adrenaline. Usually patient is having a airway obstruction. What we tend to do is give 5 milligram or 5 ml of adrenaline and nebulization as normal with the normal as salbutamol. Okay. These are my approach of a patient who is coming to the emergency department with the shortness of breath. What I summarize is you have a patient who is having a shortness of breath. There are thousands of causes patient to get shortness of breath. But remember, always remember life-threatening causes. If you exclude or if you treat these life-threatening causes, you can leisurely treat this patient on the other causes. Okay. Please think about the cause, because no point of treating or no point of giving oxygen for a patient who is coming with shortness of breath and you thinking that patient will recover. Patient definitely will not recover and patient will die in front of you. Therefore, what you want to do is, patient is shortness of breath. You need to analyze according to airway, breathing, circulation, disability, and exposure. Meantime, you need to start resuscitation. You can start oxygenation. You can give it intravenous fluid, and you need to identify the cause. Which courses wise, as I mentioned, I have listed there are significant, there are number of courses which can cause death in second or minute. Therefore, please remember this back of your mind and think about this cause is rare, these causes death. Therefore, remember these life-threatening causes and treat that causes then and there while you are doing ABCD assessment, and then leisurely you treat the rest later. Okay. My final message is all the time, patient who is coming to the emergency department, you need to identify the cause. I'm begging you, please identify the cause and treat the cause, not the treating symptoms or sign, but please treat the cause. Okay. Okay. If you have any question, I'm very happy to answer. Or otherwise, I can hand over the podium to my next speaker.
කට්ටිය නිදිද කොහෙදනේ?
ඒක තමයි මාත්
අවුරුත් නෑනේ. කට්ටිය කාලා නිදි මං හිතන්නේ නේද?
Okay, then I will stop there. Tomorrow.
Okay, thank you. Anyone
Thank you.
around? Anyone who is alive? There's a question, Bandara.
Yeah.
Anaphylaxis, if bronchospasm.
What's that?
So there's a question in the chat box for you.
I can't see it.
If bronchospasms there, adrenaline
Yes.
nebulization okay the කියලා අහලා තියෙනවා.
In anaphylaxis.
Yes.
Anaphylaxis, no need to give nebulization of adrenaline. But if you give in the adrenaline, that is usual dose 0.5 milligrams per 1 in 1,000, that is pretty much okay. But if you are really worried, if you want to really want to give, that is okay. But no need to give at all. Okay. If you're giving the adequate dose of adrenaline intramuscular, that is completely okay. Okay. But if some people who is having a like angioedema, they are much responsive to this nebulized adrenaline. Okay. Therefore, depending on this year's problem or depending on your causes, then you can give. But for anaphylaxis, patient with anaphylaxis, no point of giving if you're giving adequate dose of intramuscular. Good question. Anything else? Okay, I think there's no any question. That's all.
Okay, since someone is alive, so I have to do the presentation now.
Okay. Thank you, Veru.
Thanks, bye. Okay, can you see the screen now?
Yes, I can respond that yes, I can see.
Yeah. Okay, thank you. Okay, fine. So this is the last lecture, and then you can have a break until tomorrow morning. While congratulating all of you for finishing a final MBBS and becoming doctors and just about to start to internship your professional life as doctors, I think we are today handling emphasizing the importance of any structured approach to different emergency presentations. So this can be in your ward, maybe in the emergency department, but emergency patient or critically ill patient is a critically patient wherever it is, our approach is the same. So they have given special emphasis on these special presentations like dyspnea, as Dr. Bandar did before, and chest pain because they are common. I'll be very thankful to Dr. Bandar because he touched upon some of the scenarios I'm going to discuss here. So it will be a little bit easy for me. So, okay, so this lecture is a little bit of advanced lecture. I might skip some of the slides, but if you listen to what I'm saying, that would be okay. Don't worry about skipped slides. The chest pain in the emergency department or maybe in your medical ward. So some of you may do medicine as a part of your internship, and some may do surgery, gymnastics, pediatrics. But definitely at the end of your medicine appointment as an intern, you will become some kind of experts to the management and identification of chest pain management. But it's not only in the medical ward, because normally in our people hold on to your chest, whatever happens, maybe a sad situation, maybe a happy situation, or if they are tired, usually they hold on to their chest and say, I have chest pain. So you have to make sure there's nothing which can kill the patient within next 1 hour, 2 hours, minutes or seconds. So that is the importance of chest pain. And should not, sorry, I will go to the front, give me a second. Okay, so I don't need to emphasize that how common it is. It is very common. I am not going to give you statistics. It's very common. It's everywhere. Kids, adults, males, females, everyone at one point at their life get chest pain. But why are we worried? Because the chest pain presentation or the symptom of chest pain can be due to many reasons. As we all know, whenever we think of chest pain, what we think is, whether it is a myocardial infarction. That's what we all usually know. Whenever our mother, father, or grandparents say that I have got chest pain, at once you will feel, oh, whether they have got chest pain. That's one thing. You have to make sure that it's not there. And you, at the end of this lecture, you will understand that myocardial infarction is not the only presentation which can kill the patient coming with chest pain. So there are some other causes as well, right? Give me a second. I'm going to mute for a minute. Right. So it can present due to various pathologies of many organs. It can be the heart, it can be the lungs, it can be the rib cage, it can be the muscles, it can be the diaphragm, and that can be due to some problems with the abdomen. So it can be anything. So we need to identify which organ or which system gives that problem. Give me a second. Again. Hello? Sorry, getting calls. Fine. So we need to identify from which area this chest pain is originating and whether it is a serious cause to be considered. And there are lots of atypical presentations, so that we have to be very careful. Fine. Okay. When you think about causes, there are causes which can be imminently or immediately life-threatening. So as an intern, your duty is to identify the likelihood of having this critical cause for this kind of chest pain presentation and do the necessary. Otherwise, your patient will die in front of you. There are some causes for chest pain which are significant, but they are not immediate life-threatening, but that needs some specific treatment. And there are some chest pain causes which are very benign, and that patient can be left alone in the corner of the ward until you show this patient to the senior and get the senior's opinion for discharging the patient. But you can't keep the myocardial infarction patient in the floor of the ward. At the same time, you can keep patient with just costochondritis in the resuscitation bed. Then your consultant will come there and blaguard chase you away from the ward. That is what you need to identify. What are the benign causes? What are the bad causes? Let's see what are they. Okay, this is a comprehensive list of causes of myocardial infarctions. So as you can see here, very clearly it mentioned bad causes, not that bad causes, and benign causes. You need to identify these life-threatening causes at once. So the emphasis on this lecture will be on these life-threatening causes. In other words, big six. I'm not going to talk to you about costochondritis, viral pleurisy, chest pain due to pneumonia, hypertrophic cardiomyopathy, or what. So I will not be able to cover. So I have only 45 minutes. Within this time, I just want to make sure you know what are the life-threatening causes. In other words, big six. Okay. Now, assessment of chest pain. Let's see how you approach a patient coming with chest pain. I think so far from all our presentations done by the Emergency Medicine College, you have some idea about initial approach or the systematic approach of treating a critically ill patient on their initial presentation. So I'm sticking to the same structure. So there's no difference, because if you don't stick to the basic, you will miss some important causes and you will have a patient dying in front of you. Okay, now chest pain patient. The initial stabilization is the first thing. So we have to make sure this patient is having palpable pulse, this patient is breathing, and this patient is stable hemodynamics before proceeding to the assessment with a directed history and examination, risk assessment, investigation. You can do that. But at present, and when you are working in the ward, when a trolley comes to you, a patient coming in chest pain, you have to make sure this patient is stable or not. I think that part is already discussed. Okay, initial stabilization. I think you are familiar with patient coming with chest pain itself is a category 2 patient. When we triage them, that means patient needs higher priority of assessment and treatment. And the initial stabilization includes positioning the patient, assessing the airway to see whether it is patent, and if it is not patent, you have to make sure that it is patent, and you assess the breathing. And as Dr. Bandara said, you check for the immediate life-threatening causes in breathing part, like tension pneumothorax or bronchospasm, something. And you go on to the circulation to see this patient is hemodynamically stable. If you find that this patient coming with chest pain is having low blood pressure, you need to intervene. If you find this patient coming with chest pain is having a rhythm like this, bad rhythm like this. What is this? Can you identify what is this? Anyone? Please. What is this rhythm? Are you worried or not? Very good. Ventricular tachycardia. So this patient coming with chest pain, having this rhythm means patient is in a ventricular tachycardia. So you need to make sure that patient is not in a cardiac arrest, and this patient is not having the signs of compromise like chest pain, significant ischemic chest pain, hemodynamic instability, which need synchronized DC cardioversion to reverse this rhythm. And if the patient is having stable hemodynamics with no significant chest pain, whether you need to reverse it with amiodarone. So that you need to know. So that is the part, that is the importance of doing the initial stabilization before we take a comprehensive history from the patient. And there we assess the disability and you assess the exposure and stabilize and make sure that this patient is having a stable vitals. Now we have a living, breathing, stable patient in front of us. So we can use some time for the directed history and directed examination. This is where you get your medical school's knowledge into play. So you are assessing a patient with pain from your internship until you die, maybe as a consultant, maybe as a senior medical officer, no matter, just stick to basics. Always, if a patient coming with chest pain, this Socrates acronym to assess and documenting chest pain is important. Right? So, important. So, from the history of the pain assessment, from the characters of chest pain, from the radiation, from the social symptoms, you can have some possible likely causes. And then what you need to do is, from the history, you need to assess whether this patient is having what kind of risk for this particular causes. What are risk factors for pulmonary embolism? What are risk factors for acute coronary syndrome? What are risk factors to have this patient having acute aortic dissection, like that? So from the history, pain assessment, and the risk factor assessment, you can narrow down your possible differential diagnosis. And at the same time, examination will give you some other clues as well. And then you go for the investigations to confirm those possible diagnoses to come into a management plan. While we do investigation, I don't know whether you have already heard, there's something called risk assessment based on the history, based on the examination, based on the investigation. We can assess the risk of having that particular condition for different patients. And the doctors, the experts, scientists who lived before us, who have born and who have practiced medicine before us, have thankfully developed some risk stratification scores for most of these conditions, so that they have scientifically validated the possibility of each and every condition having with regard to these risk assessment points. So they develop different scores, and then we have already ready-made scores to be used to risk assess the patient and see what is the risk of this 85 years old female coming with left side pleuritic type chest pain and having stable hemodynamics, normal heart round, what is the risk of this patient having pulmonary embolism? What is the risk of this patient having acute coronary syndrome? Like, right, there are some risk assessment tools. When you become big doctors after your internship, you will definitely use these things in your patient care. So that is a good start for you to think about these things during your internship as well. And we have to do some directed investigations as well. Okay, so we get the patient, we do the initial stabilization, we take a directed history and examination from a stable patient, and then we do investigations and risk assessment, and then we know what is the possible diagnosis or what is the diagnosis. Then you can think of what is the definitive management for this patient. Whether this patient needs thrombolysis, whether this patient needs anticoagulants, whether this patient needs some kind of intervention like thoracostomy, then you can decide. And then based on the results of everything and this patient's stability, you can think what is the possible good place for this patient. Maybe in the HDU in the ward, maybe in the ICU. Sometimes you have to take permission from your seniors to transfer this patient to a better place to give a better care. And that's how you approach a chest pain patient. And then, as I mentioned, I will discuss some little bit of information regarding this immediately life-threatening causes. Surely, I will not be able to discuss each and everything about these causes because these are different lectures of 2 hours, 3 hours lecture, so that the amount I can cover during this topic is minimal. What I want you to have this eye-opening session. This is an eye-opening lecture to know what is chest pain, how common, what are the bad causes, what are the good causes, and how you approach. That's it. And then the individual conditions, management, risk assessment, and the risk assessment should be learned in a different way. But I would be happy to go through some critical initial steps of management so that you have some idea before you start your internship. The immediate life-threatening causes are big 6, that is acute myocardial infarction, pulmonary embolism, pneumothorax, and myocarditis with effusion, aortic dissection, or esophageal rupture. So they can kill the patient immediately or within hours. So that those are important. Acute myocardial infarction. I am not going to give you the definition of acute myocardial infarction. So that is a thrombus or the clot in the coronary vessels causing ischemia or necrosis of the heart muscles. So you know pathophysiology better than us now. You are fresh and you know the clinical presentation which is in the book. Let's see how we use that clinical knowledge you took from your books for your final MBBS in the practical scenarios. History. Okay, so again, the chest pain which described in your Davidson or your Command Clark is called the typical textbook presentation. Sometimes that is not the reality. There are instances where you get atypical presentations as well, but never forget that textbook presentation because those are important. According to the validated studies, there are typical findings which have increased likelihood of acute myocardial infarction, like gradient to the right arm, gradient to the both arms, associated with exertion, gradient to the left arm, associated with diaphoresis, associated with nausea, vomiting, worse than previous angina or similar to the previous MI chest pain, a pressure like chest pain. So that is how they present. So these are evidence-based factors. You can see usually what we typically described is chest pain radiating to the left side is the acute myocardial infarction chest pain. But according to this evidence, radiating to the right arm or shoulder has got more increased likelihood of acute myocardial infarction. This is not going to say Kuman, Clark and Davison is wrong, but the evidence suggests that you cannot neglect a patient coming with chest pain who is complaining of radiating to right arm or both arms. It has got high likelihood ratios. At the same time, there are some features which has got decreased likelihood also. Then when you hear that, we think, oh, this is not the typical MI like chest pain. So those are the pain like pleuritic, positional, sharp pain, palpation causes some reproduction of the chest pain, and there's an inflammatory location and not associated with the exertion. So those are associated with palpitation and syncope. So they might not indicate acute myocardial infarction. But the take-home message today is that no single factor in the history alone can confidentially rule in or rule out acute myocardial infarction. You have to be very careful. You have to be very careful before asking the patient, මොකෝසිය ආවේ මේක මේ අල්ලනකොට රිදෙන පේන් එකක් නේද කියලා. Never ask that, because that patient can have a acute myocardial infarction, so that none of the historical features can be confidentially rule in or rule out acute myocardial infarction. At the same time, burning pain, you say, yeah, it's like gastritis pain, yeah, burning pain. GTN එක improve now, I can sure this should be a MI. So, an abrupt onset of pain. So those features have actually no, according to the evidence, there's no actual evidence to say these have a meaningful effect on the likelihood of acute myocardial infarction. So stick to a chest pain, the textbook explanation of chest pain, but always keep in mind history alone you can't rule in or rule out, and there are lots of atypical pains as well. So atypical presentations are especially common in elderly, in women, and in diabetes. Not to discriminate in women, yes, that is our experience. They present with very atypical complaints, but ultimately proven to have acute myocardial infarction. So be careful, very careful. පත්තරේ වැටෙන්න ඕනේ නැහැ. You don't have to be in newspapers that this junior doctor has sent this patient home and scolded and sent home, and on the way home patient has collapsed and died in the bus. So we don't need to hear that. And they can present with dyspnea, weakness, syncope, and altered mental status as well. So I think these you know now. Risk factors for MI: non-coronary disease, family history, advanced age, near gender, diabetes, hypertension, high cholesterolemia, active smoker, obesity, sedentary lifestyle, and aspirin usage. These can that shows that patient is having high risk of acute coronary syndrome. Examination most of the time in acute myocardial infarction is very non-specific. Sometimes you might hear third heart sound in if there's associated heart failure and some other signs of heart failure. Otherwise, there will be no much clinical features to rule in or rule out acute myocardial infarction itself. Okay, ECG. So this is not the ECG lecture. So that ECG in acute myocardial infarction is another big topic. But the importance is a patient coming with chest pain, whatever you feel it is like, in whatever the age, you need to take the ECG as soon as possible, ideally within 10 minutes. So if you see, so for the infarction or ischemia, what you look at is T waves, which can present with hyperacute T waves in ST elevation MI, T wave inversions, and sometimes T flattening in early stages. and you look at ST segments, you see whether ST elevations, whether there are ST depressions, and try to diagnose ischemic changes of chest pain. So that I'm not going to show you any examples because I don't have enough time to do that. And the important thing again, normal ECG in a patient with chest pain does not allow safe discharge without further investigation, because again, as per history, ECG alone cannot rule out acute myocardial infarction. So you have to take both history, electric ECG features, and biomarkers to collectively to get into the conclusion of possible myocardial infarction. There are lots of things in ECG you need to know. There are early ECG changes, there are late ECG changes, there are STEMI mimics, there are STEMI equivalents. So there are lots of things you need to learn about ECG, so that other than T and SHAO changes, I am not going to tell further. I think you have to have that in a separate session. Okay, check X-ray is most of the time non-specific. As I mentioned, biomarkers like troponin has to be used, and you need to know which troponin you have in your hospital, whether it is high sensitive troponin or conventional troponin. In conventional troponin, you have to wait for 6 hours after onset or the maximum chest pain to get the result, meaningful result. And I'm not going to talk about POCUS. That POCUS means point of care ultrasound scan. This is not applicable to you in the initial stage, so that I'm going to talk about POCUS. Okay, now if a patient is presenting with ST elevation myocardial infarction, that means I don't have ECGs to show you, but ST elevation myocardial infarction, the definition is ST elevation of 1 millimeter in 2 contiguous V leads in a 12-lead ECG, in any contiguous leads except V2 and V3, where you need to have about 2.5 millimeters in males above 45 years, sorry, less than 45 years, 2 millimeters for males above 45 years, and 1.5 millimeters in females. So that is the definition of typical ST MI, but there are some other ST elevation ECG definitions as well, like posterior MIs, DV inters, like that. So you will learn what is resonance. And one of the most important skill you need to know before you start your medicine appointment is to identify ST elevation myocardial infarction in the ECG or occlusion myocardial infarction, because that means that the occlusion has got a transmural infarction. That means full thickness infarction, full cutoff of the blood supply of that particular part of myocardium, which need immediate reperfusion. Immediate reperfusion. So I will share another screen because I couldn't add that slide into this. Give me a sec. Can you see this now? I think you can see now. So the chest pain. So if the ECG shows ST elevation, that's a ST elevation myocardial infarction. And if the patient does not have ST elevations, you have to go for the troponin I values. If it is positive, or if the patient is having suggestive ECG changes with positive troponin I, that means there is a myocardial injury or myocardial infarction causing biomarker release. So it is a myocardial infarction, but not ST elevation. So it's called non-ST elevation myocardial infarction. And if the patient is having negative troponin I, that means there's no dead myocardium in patient's heart. So there's no necrosis of myocardial cells or endocardial cells. So even though patient is having typical chest pain plus or minus ECG changes, So then we can label that condition as not a myocardial infarction, but an unstable angina, right? Okay. Right, this. Assume this patient is having, assume this patient is having respiratory myocardial infarction, so that you need to go for urgent revascularization. So that means artery is blocked, you need to open that up. There are two ways of opening that up. That means either you can give fibrinolytics like streptokinase, like tenecteplase. You have to block the, like in a blocked pipe in your house, you need to unblock it as soon as possible. This is time critical. So you can use fibrinolytics, medical revascularization, or if you are in a place close by to a PCI center or a place which has got cath lab to do an angiogram, you can go for the primary revascularization with a percutaneous coronary intervention. So then your role is extremely important here in the ward to identify ST elevation myocardial infarctions and inform your seniors to go for immediate revascularization therapy. Unstable anginas, you don't have to worry that much because it's not that time critical. For the non-STEMI, non-ST elevation myocardial infarctions and unstable anginas, what you have to give is to anticoagulants. Anticoagulant means either heparin or enoxaparin. For both these patients, as Bandara said before, you have to give antiplatelets as soon as you identify or you suspect acute coronary syndrome. Aspirin 300 and clopidogrel 300. Those are the first drugs, antiplatelets, and then you have to decide on enoxaparin or revascularization therapy. So that is the ST myocardial infarction management in very brief. So as I mentioned, there are risk assessment tools. So just remember that there are some risk assessment tools like hard score. We prefer hard score because that gives an idea to, you can just Google and see what is hard score. It's not a thing I'm going to cover here, which give the probability of this patient having a myocardial infarction. So that just to the moment know about that. So I'm not going to tell you further regarding these scores. Okay, second condition of the big six. I will just go very fast now. Okay, now aortic dissection. You might have heard in your clinical medical college, but you might not have seen it. It is not that common, and it is a result of, it is 3 per 100,000. So that is not very common. What happens is there is a breach in the intima of the aorta and the blood seeps into the space between the media and the intima. That means inside the aorta wall. So whenever there is high blood pressure and tachycardia, they just dissect the arterial wall and then cause the false lumen like this, and false lumen, and cause narrowing of the intima of the actual blood vessel. At the same time can block the branch vessels as well. That's what happens in aortic dissection. You might have heard about different types of aortic dissection. So type A and type B aortic dissections are there. So type 1, when the type A is when the arch of aorta is affected or the ascending aorta is affected. Type B is when the ascending aorta is not affected. So that is the pathology in brief, very brief, of aortic dissection. right? How do they present? How do they present? Again, history. Sudden onset, sharp, the worst ever pain patient can imagine. It is sometimes described as a subarachnoid hemorrhage in the chest, ripping tight, tearing, maximum severity in that onset. Most often begins in chest and they can begin back as well. It can be migrated because it dissects the aorta and then it migrates. So it can be migrating pain. Since it can block the vertebral vessels, carotid vessels, renal vessels, it can present as stroke, so chest pain with stroke, chest pain with hoarseness of pain, chest pain with altered conscious state. Because usually, if the patient is non-hypertensive, acute myocardial infarction cannot cause altered conscious state, but this can, and they can present with typical atypical chest pain with acute coronary syndrome. They present with inferior MI because that can cause right coronary vessel as well. And they can present with mesenteric ischemia. They can present like a kidney stone as well. So you need to identify very rare, but you should not miss this condition because then that means you need to know how they present and what are the features of aortic dissection. Okay, there are lots of aortic risk factors for aortic dissection. All these conditions either hereditary or acquired, congenital or acquired causes which can cause some weakening of the aortic wall. I'm not going to go into further detail there. They are really ill patients. They are very sick. They come with screaming in pain. They are diaphoretic, hypertensive. That can be hypertensive as well because hypertension itself can cause aortic dissection. They are tachycardic and they can have differential blood pressures, different blood pressure in the right and left arm, 27%. And they can have some new murmur as well. And they can have, as I mentioned, chest pain plus something else like neurological findings. And ECG, they can have some ischemic changes because of right aortic coronary artery occlusion. And there can be some non-specific ST and T changes as well. I think you might have heard about the possible chest X-ray findings of aortic dissection. There are many. Mainly what we say in our practice is wide mediastinum, loss of normal aortic knob contour, and globular heart, pleural effusion, trachea to shift into the right, left main bronchus shift into inferiorly, and sometimes they can have normal chest X-rays as well. I think this is one example. You can see wide mediastinum with loss of aortic knob. Okay. So the definition diagnosis with the CT angiogram or the autogram. So you will can see the intimal flap here. So this is the flap of the aortic dissection. And this is the false lumen. And this is the true lumen. This is the true lumen here. This is the false lumen. This is the true lumen. So this is the dissected part of the intim. Very interesting. Very interesting. Okay. I'll erase this. Right. Oops. Okay. So once diagnosed, you need to do thorough, robust resuscitation. You have to make sure ABCD is stable. If the patient is hypertensive, you need to reduce the blood pressure immediately because hypertension worsens the condition. So you have to target systolic blood pressure 100 to 120. At the same time, tachycardia also worsens the condition. So you need to reduce the heart rate. So ideally, you can use IV beta blockers like propranolol, labetalol. And then the urgent cardiothoracic surgical team will decide on the operation, and then they might probably take it, especially if the aortic arch is not affected. Okay. This again a risk assessment score based on the history and examination findings. I'm not going to go into that detail. That is the end of that condition as well. Third one, pulmonary embolism. I think Dr. Bandara also discussed about pulmonary embolism, so that I'm not going to go into major details. So this is 1 in 1,000 patients, common. You might not see much in this setup. Maybe we are not diagnosing enough. Patients are very widely diagnosed in European and other countries. So what happens is patient is having some kind of blood clot, maybe in deep veins, maybe in the pelvis, or maybe in the IVC, maybe in the pelvis, maybe in the deep veins, pelvis, or IVC, which can migrate to the right heart and then into the right ventricle and to the pulmonary artery, so that they can block the pulmonary artery, so that there will be some perfusion defect to the lung. So there is a pathology. So what happens is a clot dislodges and block the pulmonary arteries. So this can cause perfusion lung mismatched, and then there will be a perfusion and ventilation mismatch, VQ mismatch, which can cause hemodynamic compromise and hypoxemia as well. So history. Typical presentation is dyspnea, fluid chest pain, substernal chest pain, cough with hemoptysis, and sometimes syncope, especially if it is a massive pulmonary embolism, big pulmonary embolism causing a big block in the pulmonary arteries. Okay, risk factors. So that again, this is very important to know the risk factors, because a patient coming with chest pain with these risk factors, you need to think about that. Otherwise, you may think as acute coronary syndrome, and you might think you about like pneumonia, musculoskeletal pain, never diagnosed pulmonary embolism, and at last patient will die. And you will write the DC as something which is familiar, but actually what is there is pulmonary embolism. So past medical history of venous thromboembolism, pregnancy, family history of venous thromboembolic disease, recent prolonged immobilization more than 3 days, major surgery within previous 12 weeks, fracture of lower limb within previous 12 weeks, active cancer within previous 6 months, or recent treatment of palliation. Those are the risk factors. So we need to think of those as well. Okay, examination. Patients are tachycardic. Patient may be distressed. They are tachypneic, and hypertension in high risk or major pulmonary, because in the full blood flow is fully blocked in right atrium or pulmonary arteries, that will cause poor blood supply to the left ventricle or the obstructive shock, causing hypertension, and they are hypoxemic, and they can have a little JAP, and if you are lucky, you might feel hear some pleural rub as well. You might be able to find evidence of DVT in this patient. ECG. So the typical S1Q3T3, which you have learned in your medical faculty, is unfortunately seen in only 1/5 of patients, when if they have a significantly major pulmonary embolism. What you can commonly see is just a sinus tachycardia or evidence of right ventricular strain. That means right bundle branch clot, right axis deviation, and the possible P pulmonale, big P's. And they can present with arrhythmias as well. Chest X-ray is most of the time not diagnostic, it's normal, but if you are very lucky, you might feel something which I have seen like this, a Hampton's hump, which is infarction of the pulmonary of the lung due to pulmonary embolism. So I was lucky to see this. Okay, and focus, I'm going to skip. Okay, now if the patient is having just think about this thing. And again, you need to use some risk assessment tools, because unlike myocardial infarction, it's not very easy to diagnose. And the diagnostic test, CT angiogram, is not widely available in any country. At the same time, it is costly. At the same time, it involves lots of radiation. At the same time, it involves giving contrast, so that it's costly. It has got a risk of radiation and contrast induced problems as well, so that we can't do CT angiograms like we do ECGs for every patient coming with chest pain with suggestive fear. So that you need to risk stratify these patients and use some simple diagnostic tests to identify these patients. So that's why you have got Wells score. You might have heard that. Wells score or modified revised Geneva score. So you can use either of them. My favorite is Wells score. You can risk stratify whether there is a low risk of P, whether there is a moderate risk of P, whether there is a high risk of P. So if the patient has got high risk Wells score with your clinical suspicion, you have to think of doing imaging. You are not going to do D-dimer. You have to go for definitive diagnostic, whether based on your renal functions and everything, you can decide whether you are going for a CT pulmonary angiogram or a VQ scan. So I'm not going to go into details. Who is that? Okay. Fine. Right. So if the patient is in high risk category, you do definitive diagnosis with the imaging, and you can rule in or rule out pulmonary embolism. If the patient is in low risk category, there's something called PERC rule. PERC means pulmonary embolism rule out criteria. So if the criteria is negative for all the points, that means patient is having no PE. I will tell you what is PERC rule. So this is just a briefing, just a summary of everything, so that you can learn on this later, right? So if the PERC rule is positive, so that means patient cannot be ruled out clinically from pulmonary embolism, even though the patient falls into low risk category, so that you need to go for a D-dimer test. If the D-dimer test is positive, you need to think that this patient is having possible pulmonary embolism and go for imaging to diagnose pulmonary embolism. And if it is negative, again, you can rule out P. That is the workup of pulmonary embolism. When you have possible, diagnostically possible pulmonary embolism with hemodynamic instability, sometimes you might not have enough time to do all this investigation. But if the patient is having shock or hypotension, you need to think that this patient has got a big pulmonary embolism. That means a saddle-shaped pulmonary embolism can, or high risk big pulmonary embolism. And I will tell you what is the importance of this big pulmonary embolism if the patient is coming with signs of hypotension. There is a difference in the management. Okay, this is the criteria. So know that I know you cannot remember per criteria from this lecture alone. So these are the components of per criteria. Know that there is something called per criteria. Know that something called Wells criteria is there, and then you can just Google it. Just do MD calc and then tick tick tick. You will get the score. So just use that. Know that there is something called Wells and per criteria for the risk assessment and diagnosis of pulmonary embolism. Treatment is anticoagulation if the patient does not have hemodynamic compromise. If the patient is stable, you have to go for anticoagulation, maybe with enoxaparin, maybe with heparin, or thrombolysis, or if the patient is having suspicious of pulmonary embolism, hemodynamic unstable, so you have to do direct intervention like surgical embolectomy, catheter-directed fibrinolysis, or systemic fibrinolysis or thrombolysis with alteplase to get rid of that big block. That is all about pulmonary embolism. So we are now close to the end. If you are still there, fine. Tension pneumothorax. I think Bandara explained. So this is a fourth cause of immediate of a condition which can kill the patient immediately. Tension pneumonia, not open pneumothorax, not non-tension or simple pneumothorax causing immediate death. But tension pneumothorax can cause without trauma and they can die. So history, very simply, coming with pleural type chest pain and acute onset shortness of breath or worsening shortness of breath. And risk factors: smoking, tall thin people, muffins, pregnancy, familial pneumothorax, past history of pneumothorax. Examination, you know that. Tachypneic, hypotensive, because it's tension. It has got obstructive shock. So tachycardic, hypoxemic, elevated JEP, unilateral diminution entry, hypercussion node, subcutaneous emphysema, tracheal deviation, deviated apex beats. So this is a clinical diagnosis. You don't have to go for an X-ray to diagnose tension pneumothorax. So this X-ray should not happen, should not have happened because this is a clinical diagnosis. Patient can die while awaiting this chest X-ray, so that you don't have to look over chest X-ray. If it is not a tension news, if the patient does not have evidence of tension and if they are stable, yes, you can go for a X-ray. Focus, just forget about focus. And then ED management is urgent needle decompression, as Bandar said, at the safe ankle, followed by intercostal catheter. Oops, sorry. Okay, going for the end. Pericarditis, myocarditis, pericardial effusion with tamponade. So these are not uncommon. There are some cases of these coming with chest pain, atypical pleurotype, pericarditis chest pain, having hemodynamic compromise because due to pericarditis or due to some other causes, which I'm going to tell later, they can have got a big collection of fluids or blood inside the pericardial cavity, causing compression of the right ventricle so that heart cannot accommodate adequate volume of blood to be pumped to the pulmonary vessels and eventually to the left side of the heart. So it's an obstructive shock. So it's an atypical retrosternal pain, pleuritic and positional. If the patient is having tamponade, you can have some dyspnea and dizziness as well. Acute pericarditis can be caused by infection, malignancy, uremia, and that can be traumatic as well if there's a history of trauma. If there is a tamponade, what we need to do is we need to get out of the we need to get the pericardial fluid or blood out of this thing to decompress the heart. If it is not, if it is pericardial without effusion, you can use symptomatically. And the examination findings, you know, when there is a tamponade causing obstructive shock, it's called Beck's triad, elevated JVD, muffled heart sound, and low blood pressure. That's called tamponade features, examination features. Pericarditis, they can be feverish, they can have some tachycardia and pleural lumps. ECG have got saddle shape ST elevations in all the leads except AVR. So AVR ST depressions, saddle shape ST elevations in all the other leads with PR elevation in the AVR and PR depressions in all the other leads. That's the typical ECG findings. Chest X-ray might show there's some globular heart due to effusion. And as I mentioned before, management is if the patient is hemodynamically unstable, you need to go for an urgent needle pericardial, so that you need to call your boss and your seniors and get the things arranged by experts. Short thing about the sixth of the big six, sudden onset esophageal rupture or mediastinitis of any cause. These are very critical ill patients, very rare, not that common, but that can cause. Acute esophageal perforation can be due to vomiting or retching, forceful vomiting or forceful retching, causing intraesophageal pressure rise, causing esophageal rupture. And other than that acute spontaneous esophageal rupture, it can be followed by recent upper endoscopy or some other instrumentation of upper airway or the esophagus. And mediastinitis without esophageal rupture can be due to spreading of infection from teeth or odontogenic infections. So they're ill, they are shocked, they are tachycardic, feverish, subcutaneous emphysema can be palpated clinically, and they can have some epicardic tenderness as well. ECG is non-specific. Chest X-ray might show evidence of gas everywhere. Pneumomediastinum, pleural effusions, pneumothorax, and CT X-ray with oral contrast will confirm. So CT is most of the time diagnostic. They are very ill. They need immediate resuscitation with antibiotics, fluids, and urgent cardiothoracic referral for operation and debriefing. They don't have a good prognosis anyway. That's all about big six. You are tired, I know. So the causes, as I mentioned, I just touch upon these six, and there are important differentials here as well. Pericarditis without tamponade, myocarditis, viral, that can cause problems. Unstable angina, even though it's not a myocardial infarction, that is a critical finding. You need to admit and do properly. Prince metal angina, coronary vasospasm, simple pneumothorax, pancreatitis, mediastinitis. So they will have some high risk features which has to be managed, but I am not going to talk about them. And non-agent, stable angina has to be admitted if it is worsening, but not that urgent. Hypertrophic cardiomyopathy can cause chest pain sometimes. Viral pleurisy, pneumonia, costochondritis, chest wall injury, cholecystitis, esophageal reflux, biliary colic, and herpes zoster. Very important to identify because you might treat for muscular pain, costal pain, and everything without examining the chest. That's a failure. So you have to identify the herpes zoster rash in the chest. Very common, very common. And then it can be due to malignancy. At last, after excluding everything, you can say this patient can be coming with possible psychological or anxiety-related presentation. So, but you don't do it on presentation at once. Okay. This is a little some interesting management algorithm just before I wind up. So any patient coming with chest pain, so as I mentioned, assess vital signs, put into cardiac monitoring, get IV access, give oxygen if needed, and give focus history and physical examination once they are stable. Unstable patient with chest pain, do that ABCD assessment, unstable patient. And then, so manage accordingly, as I mentioned. If the patient is stable, take him to a ECG. If the patient has no evidence of aortic dissection, that typical history, you can give aspirin at that moment. And if the ECG is diagnostic or suggestive of acute coronary syndrome, if you need to see whether this patient is having possible STEMI, possible non-STEMI unstable angina, and then manage accordingly. And if the patient is not having possible features of acute coronary syndrome in chest X-ray, so you have to go for other possible investigation, that is chest X-ray. Chest X-ray can identify pneumothorax. Chest X-ray can identify most of an aortic dissection. Chest X-ray can identify evidence of pneumonia or sometimes heart failure. So you have to do the necessary actions from the chest X-ray diagnostic things. And then if the chest X-ray also normal, so the ECG does not have evidence of acute coronary syndrome, and the chest X-ray also normal, then what we are going to do? Then we have to think of some other bad causes, like pulmonary embolism, like acute coronary syndrome without ECG features, pericarditis or tamponade. So pulmonary embolism, you need to go in that algorithm to confirm the diagnosis. Acute coronary syndrome, even though there's no ECG changes, if the patient is having chest pain significant, you have to go for the cardiac markers and do the rest of the management. And pericarditis and tamponade, history and examination to identify the possible likelihood of pericarditis and tamponade, and you have to decide on definitive management. This is all about chest pain, critical presentations of chest pain. That's all. Thank you very much. And if you have any questions, if you are not that tired, I'm happy to answer any questions. If you are alive. So as I promised, I finished by 4 o'clock. Thank me. If you don't have questions, actually I can wind up today's session, emergency session. And I think the person who is coordinating, I don't know, I can't remember the name, said that you have got the pediatrics session tomorrow by 8 o'clock. And thank you very much. And in the absence of any questions, I will wind up. Take a break. Have fun.